Now, if this case has other variants, there is what we call the Columbia classification, where we have 5 variants. That one is one of them, the higher variant tip, not otherwise specified, and then a mix. So it could be any other of those forms, but not the H. variant. So that one was also unlikely. Then the third one was syphilis with associated nephrotic syndrome. Now, a positive TPHA, it is not really diagnostic of active syphilis. By the time someone presents to you with active syphilis, and the syphilis, the one explaining the nephrotic syndrome they are presenting with, meaning the VDR is positive, or your RPR, they are going to be positive. So before you treat it for active syphilis, you have to first request a TPHA or an a VDRL or RPR. Then when you get them positive, then you'll be like, okay, this is active syphilis, which is most likely positive the gene, giving you a pure nephrotic syndrome. But this is not the case we are seeing. And still, even when you saw, I think was on weekly doses, by the time the patient presented received, I think, over 4.
Yeah. 4.
Yeah. So in syphilitic nephrotic syndrome, the nephrotic syndrome will burn out as soon as you start the injection. Those antigens will disappear, and then you lose some epithelial deposits, and then the nephrotic syndrome will automatically improve without any other interventions. That is not what we are seeing here. Then now you come to the patient, obviously had hematuria, then now has the granular casts. So if you look at the whole patient in totality, this is a patient who the symptomatology was over 3 months. Was it over 3 months? So by definition of CKD, abnormal structure and function for more than 3 months. Either functional or structure-wise, it brings you to have CKD. Now the cause at this point in time, you don't know, but you have a proof that it's a gene. And the gene, it is a nephrotic. Reason being, the patient has RBCs in the urine. They have hypertension. By that point in time, you're on amlodipine. And I think at some point in time was an diuretic. Yeah, was on a diuretic, and your BPs are fluctuating in 130, meaning it's that hypertension that are normalizing. So there's evidence that there is hypertension. Then you have the RBC. Then obviously you have the raised creatinine, which was at that point in time, initial presentation in Molag was around 200. And then you have the edema, low albumin. So it's obvious it's a nephrotic, but you don't know which one is it. So you better call it unknown cause. Now presenting to you with granular casts. Now meaning there is an ATN. Now this is most likely a patient who presented to you with nephrotic with hypertension, edema, and then got an AKI. Now AKI is a common complication in nephrotic syndrome. And the mechanisms are many. Your diuretic switch to giving the NSAIDs if the patients are in pain. Then obviously the disease progression. Then if you are aggressive on your diuretics, some patients get septic ATN, and then they can develop ATN. This is the picture which we are seeing. And by the point in time we are seeing the patient was already polyuric. So the only way you could get the best answer for this patient is by you doing the biopsy. So you have a clear answer. Given the fact that the kidneys were borderline 10 and 11, and then still your initial creatinine was in the 200s, meaning you had a lot to salvage. The eGFR at 200, which we think probably was the patient's baseline, you could have a lot to salvage. But I think the patient never had money. Yeah, the patient never had money. And then we just call it off. Just manage your AKI, and then you go ahead to manage the CK. There is not much you're going to do for that patient. Obviously, the substitution has to be done from the tip. Now, whatever kidneys which are prime, however much it's not the TDF nephrotoxicity, when the kidneys are already prime, it's better remove the TDF. Reason being, you have to renodose it if you're to maintain it. And most times, people rarely are they going to renodose your TDF. Sometimes even the lower dose preparations are not there. So it's better get rid of it. And then for the finerenone, now people have a tendency of prescribing finerenone obviously the SGLT2 patients, yes, fine, we know there is benefit, especially for SGLT2, but still ask, because I don't know whether Mulago has free SGLT2. So if it's not there, you ask to be there. So if it is there free of charge, you can give the CKD patient. All cases right now, whether proteinuric, non-proteinuric, there is benefit. Apart from the non-proteinuric indication, the SGLT2s will inhibit renal fibrosis, and then at the end of the day, reduction in the loss of the glands and in the interstitium. So you have benefit both in the proteinuric and in the non-proteinuric CKD. For finerenone, it will reduce proteinuria, and then also it has antifibrotic property. However, it has been well studied in diabetic populations. If you read the Figaro Fidelio private, that is where it has more benefit. Studies are just ongoing in the non-diabetic population. So until we get much evidence that they benefit, that is when we shall be kind of free to prescribe them. If you're prescribing them now, yes, theoretically, you might think there is benefit, but still remember the cost. If you go and inquire how much a 20 milligram dose per month costs, first always ask the patient. Now, the patient who cannot afford biopsy, I wouldn't waste time prescribing them. They are not going to buy it. They will just buy 1 or 2 weeks and then they stop on again. So yes, I think had some pills around 20 of them, and then you just advise you just continue your medication, because after all, they don't have money interference with the treatment compared to the SGLT2s. If it was the SGLT2s at this point in time, because of the AKI, would stop them, because they are going to interfere with you. They will cause a 30% rise in the treatment, which wasn't the case for this patient. So it was the CKD, cause unknown, but it was a nephritic nephrotic. Whatever gene lesion, most likely is a mesangiocapillary. Unlikely to be membranous. Now, membranous is one of those common causes of a pure nephrotic syndrome. Unless you have presenting transformation of the membranous, that is when you will have the hematuria. But if they are asking you the common cause of a pure nephrotic syndrome, number one is membranous, the primary and second. Then FSG is also primary and second. So in this picture, labeling the session as the one having a membranous, it's very unlikely. Which membranous? So the most likely reason is the mesangiocapillary. And mesangiocapillary can be due to so many causes. So mesangiocapillary, or what you call the membrane proliferative lesion, it is caused by so many other conditions: lupus, IgA, post-infectious, UC3 genes, the dense deposit is a C3 glomerulonephritis, then you can have the monoclonal gammopathies and so many other things, the cryoglobulinurias and other things. So for this patient, unless you could do biopsy, you could have an answer. So Uganda will still have a long way to go. Unless we improve our histopathological services, then the nephrology services are going to continuously kind of be poor. Because even where we are sending specimens, I think someone was calling me in the clinic, but we have that patient big biopsy. And then the lab was busy sharing things like what clinical said. Those are clinical notes, which we never sent them. And that is the same lab which gave us results on the other lady who had a positive ANA, I think normal complement, cannot conclude whether it is a mesangiocapillary lesion. They have all negative IF staining, which doesn't even in FSGS, you might get a class 1 IgA, because most of those lesions are immune-mediated. So some of us, like me, have stopped doing biopsy until we improve the histopathological services, because it's very disappointing for you to risk a patient with biopsy, and then you send it to someone who is just going to gamble around there with a specimen. Now, some of you have never seen what can happen when you do biopsy. Almost all the products, before you qualify, you will have caused the defectum. Yeah? You get biopsy on someone and then you cause a defectum. Now, remember, these patients will come into you walking in, and then before you know it, you're busy telling them how you're going to remove the kidney, punch it. Eh? Now, if you're punching it and then you're going to get bogged without movement. All right, thank you.
Thank you very much, Dr. Fernandez. And since he's also standing in for Dr. Nakwagala, the patron of complex case, and this being our last complex case presentation for the year and the semester, so we beg to have the one from you so that it closes.
No, I think Dr. Nakorash sent a WhatsApp. I think he was not going to be able to come. So unless people have any other concerns, I think you can invite the other team there.
Thank you very much, Metrology. So let's have the one from our sponsor. So, I don't know if you have any like a place where can be down. Come again? Where can you stay? But which place?
So we are going to try to figure out